This event is a speaker series. This is our second speaker this year. And I want to tell you a little bit about the series. It's sponsored by the Seattle Pacific University, and especially the School of Psychology, Family, and Community Initiative for Individuals with Intellectual and Developmental Disabilities. And the initiative's been going for the last 5 years. And part of our mission is to educate SPU and the larger public about disabilities. We want people to know about different disabilities and what's happening in that area, what the needs are of different individuals, and how we can support families and individuals with disabilities. So we have another speaker series, actually 2 speakers in April. I just want to mention that. We'll talk about it. We're doing autism awareness in April. And we have a resource there in the morning for families and individuals on the spectrum. And we also have Annette Estes, who's going to talk about early identification and early intervention for individuals on the spectrum. And then in the afternoon, Gary Stobie, a local psychiatrist, is going to talk about the transition from adolescence to adulthood, which is really a neglected area in the field of autism. So that is on April 11th. So we'll send out some email blasts about that as well. Today we have with us Dr. Ladish, and she's a pediatric neuropsychologist. She earned her PhD at Washington State University, and she completed internships and fellowships at the University of Washington and the Stanford Schools of Medicine. She is currently the director of the Pediatric Psychology, Psychiatry, and Neuropsychological Services at Mary Bridge Hospital, where she's been working for the last 16 years. She's also the chair of the Multi-Care Interdisciplinary Concussion Board and a psychology consultant to Mary Bridge Trauma on concussions. Dr. Ladish also makes numerous presentations. We were just talking about her area of expertise extends well beyond concussions. But this is an area we haven't really talked about in our initiative, but I think it's really an important area for us to learn what's happening in this field. There's a lot of changes, and I think she's going to give us some updates and kind of research going on. So thank you so much.
You guys hear me okay? I will, true confessions, few of them actually, but my first true confession is I've had about 3 Cokes within the past 3 hours, so if I start talking too fast, feel free to give me a little signal to slow down a little bit. I have been interested in this field for some time. When I first came over to Mary Bridge, I was brought on as the only neuropsychologist. Mary Bridge became a level 2 trauma facility about 16 years ago when I came to Mary Bridge. And so we got a lot of kids that used to fly over us to Harborview, started to come to Mary Bridge with falls, skiing accidents, falling out of windows, you name it. We've seen all kinds of things. So predominantly my role was consulting to kids in the hospital at the bedside. Now I have the opportunity to do more work with them as outpatients, and we see athletes as well as non-athletic but very active kids. And so I'm going to present to you sort of the latest and greatest information on both returning to play as well as returning to learn. And I think that the information is important and helpful information to have. I'm going to try to leave plenty of time at the end for questions. I'd rather save them to the end because my bet is I'll hit on some of the information you may have questions about as I talk. But if I don't, please jot them down and we'll make sure that we go over things. So in terms of the learning objectives, what I'd like to start with is talking just about the general physical, cognitive, and emotional symptoms of concussion to make sure we all start on the same kind of fundamental page. We'll discuss the educational implications of concussion symptoms and how those impact kids in the school and learning environments. I want to talk a little bit about understanding the risk factors that would predict a potential longer outcome in concussion or a more challenging outcome in terms of concussion recovery. And then we're going to talk about how to assist in the development of more appropriate, primarily educational, potentially some physical, and certainly cognitive recommendations to assist kids as they're getting back to learning environments after sustaining a concussion. The other thing I can certainly say is, you know, I am wearing all my hats when I speak. I've kind of been exposed to this from a lot of different schools of thought, as well as a lot of personal schools. So certainly done research and background in concussion as a neuropsychologist. I sort of more, you know, from a research basis, know a lot about concussion. I was a collegiate athlete when I was going to college at UCSD on our soccer team, so I've sustained a concussion or two. One that we know of, I'll leave it at that. And my son, who's now 12 at the age of 4, fell down a flight of stairs and had a concussion and spent a night in Mary Bridge. So I've been on the receiving end as a parent of a little one who's had a concussion. And so I think those things are helpful in terms of informing me about what I think might be useful for you to hear about. So you know a little bit about me. I don't know as much about you. I understand that predominantly a lot of you are psychology background, educational background, graduate students. I assume some of you are professional individuals. Anybody parents? So we got parents in the group as well. Physical therapists, occupational therapists, athletic trainers, physicians, any physicians in the group? I do know Gary Stobie. You guys will look forward to hearing him, and Annette Estes, so I was excited to hear that they're going to be coming and speaking to you. Please, you know, there's no such thing as a bad question, so feel free to ask questions as we get towards the end. I welcome all of them. The first point I want to start with is definitely a concussion is a brain injury. You know, I think in probably the past decade, we've kind of moved in that direction, but prior to that, you used to hear almost a distinction between a concussion versus a brain injury, and that's really not the way we're thinking about it anymore. Some of the terms that we want to avoid, or at least that lend themselves to minimizing the symptoms, are things like a ding, an individual getting his or her bell rung, saying that the individual, quote unquote, just saw stars, or that it's, quote, just a concussion. You know, concussions are very real events. The symptoms can be, you know, momentary and short-lived to very long-lived. I'm working with a athlete getting ready to go to college now who's been dealing with kind of a prolonged sequelae. I won't say she's still actively concussed, but we're now into year 2, and her life was dramatically altered relative to concussion in terms of how she finished her education and how she went on to make choices. So, you know, they're very real consequences. Some of the basic facts about concussion in children, well, in general, 3.9 million activity sports-related concussions per year per the latest CDC estimates. CDC has a lot of great literature out there if you want to look up some basic handouts and educational materials for parents, nursing, schools. Go to the CDC website. Some of the primary you know, precursors to concussion: falls, accidents, and assault. I think we're moving in the right direction. There's a little bit, I think, of catastrophic thinking is sort of how the professional world is thinking about it, with some of the media attention to concussion, but in generally I would say it's good rather than bad. You know, from my purview, we've kind of gone to 10 years ago where I had to convince some, you know, physician providers who would cancel. I'd get a neuropsych consult for a kid in the hospital for a consult with concern for concussion, and some physician would cancel it and say, oh, he didn't have a concussion, he just fractured his mandible or blew out his orbit or had a nose fracture. I'm like, well, the nose bone's connected to the head bone. So we've moved in the right direction from there. I think people know that you can get hit almost anywhere on your body and potentially sustain a concussion. But now we've kind of moved. You hear a lot about the professional athletes, and there's a lot of attention to the very serious traumatic effects of concussion, things like second impact syndrome, isolated students who have suffered death following second blow and cerebral swelling, chronic traumatic encephalopathy. Those are certainly very real things. I wouldn't say that's really where the bulk of this information needs to go, though. So while those are the horrific outcomes, and that's what our legislation is based on, importantly, I want you to take away the belief and the understanding that in the vast majority of cases, these individuals fully recover. And if we pay and heed good attention to their symptoms, our symptoms, whoever's it might be early on, very positive outcomes are, by all means, the most likely outcomes. All states now, nearly all states, I think with the exception of one, I'll show you a slide later that kind of shows where the legislation is at, have legislation regarding concussion management. Washington, yay, Washington, we're the first state to have legislation regarding concussion with the Zach Lysted law. Zach Lysted was a Mount Tahoma middle school student who sustained a blow on the field, was allowed to go back onto the field, sustained another blow during play, and pretty immediately started having cerebral swelling, was life-flighted to Harborview, was in a coma. Well, first he had surgery, was in a coma, I think, for a little over a year, and is sort of permanently devastated from that injury. His parents and Zach himself have been very instrumental working with the NFL and with the Brain Association of Washington in getting legislation started. And so we now have the Zach Lysted law, which requires that any athlete injured on a school-based playing field or anything sponsored by school-based sports be taken off the field and evaluated, and is not cleared for sport until they're further evaluated by a licensed professional. So we've come a long way, and I think it underscores the importance. There is a group of professionals that meet every so many years in Zurich. This is sports medicine physicians, surgeons, neuropsychologists, neurologists, tends to be in Zurich, who developed a consensus definition for concussion. And it's defined as a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces. So basically, any strong force impacting the body can result in concussion. I think these next points are important. It may be caused by a direct blow to the head, face, or neck, or elsewhere on the body if the forces are transmitted to the head. So whiplash injury, you know, going 100 or let's say 80 miles, 70 miles in a car that stops abruptly. If your head and neck are smacking forth, being struck on a ski slope, on a snowboard, things like that can certainly result in concussion-like forces. And so it's important to understand that you don't have to have wonked your head to have concussion-related symptoms. It typically involves a rapid onset of short-lived, and I want to underscore short-lived symptoms, you know, impairment of neurological function that tend to resolve spontaneously. Time is definitely on our side with concussion, and if you did nothing, most symptoms tend to resolve over time. And these clinical symptoms largely reflect a functional disturbance. So there's a disturbance in the individual's neurological functioning rather than a structural injury. If you do CT scan and concussion, you know, 99.9% of the time you're not going to find anything. That doesn't mean that the individual didn't have a concussion. CT scan is actually not helpful in concussion unless you have prolonged symptoms where you're looking for something like a bleed or a fracture. But unless you have a reason to CT, concussion in and of itself is not a reason to CT. Also, it results in a graded set of clinical symptoms that may or may not involve loss of consciousness. And one important point I'd like to raise is loss of consciousness does not predict severity of concussion. So, you know, we no longer ask, oh, but did they have a loss of consciousness? That really doesn't matter. You know, many factors predict how a person responds when they've had a blow to the head. Or whether or not they're going to have long-standing concussion symptoms, or how long the concussion is going to last. Loss of consciousness is not one of them. Probably a degree of post-traumatic amnesia would be the most predictive thing if you were to isolate one symptom. But there are a lot of sort of risk factors that we'll talk about that also would predispose to a better or poorer outcome. So I was mentioning the CT statistics before. So this is an interesting literature taken out of PCARN, which is the Pediatric Emergency Care and Applied Research Network. And they looked at the CT scanning rate for individuals presenting to an ED with brain injury. And they found that for individuals with head trauma, the CT scan rate was 35.3%, whereas the traumatic brain injury rate was 5.2%. Of the individuals that were scanned, 0.9% of them, less than 1%, were found to have what they defined as a clinically significant traumatic brain injury, meaning that there was a bleed, there was a skull fracture, there was something that they found, diffuse axonal injury, something worth monitoring over time. But even with that, in less than or around 0.1% of those cases, was there anything neurosurgically to be done. So even if something was found, we were just monitoring it. We weren't necessarily going in neurosurgically. So, you know, I as a parent, and I felt it myself when my son had his concussion, you know, that urge is, oh, scan him, scan him. You want to get this clean picture that nothing's there of concern. But the bottom line is, the likelihood is there is nothing there of concern, and we're really feeling that better to wait and watch than to give a dose of radiation for no good reason at all. 2012 was the more recent meeting of the Zurich panel, and some things they added in terms of updates. We were already here with the Zach Lystad law, but they're putting out kind of internationally that an athlete should be removed from the field if a concussion is sustained until further evaluation is done. They updated the sports concussion assessment tool. We were at SCAT 2. They updated a SCAT 3 version. And now they also have a child SCAT 3 to look at pediatric patients. I think it starts as young as 5 years of age. So there are a lot of tools now, sideline-based assessment tools that we can use. It was also stated and kind of put into writing that concussion is an evolving condition. One of our neurologists just sent us, the neuropsych service, an article just the other day about management of concussion and looking at some factors, and wanted to get our input. And one of the comments I actually wrote back to him was, gosh, you know, it feels like it's maybe equal parts science and standard of care medicine, and art form, and sort of nuancing and finessing your treatment based on the individual's unique presentation. So it really is kind of an evolving condition, because all of us, all individuals are evolving, and you really have to kind of monitor symptoms periodically throughout time. This is not the kind of condition that you sort of make a set of recommendations and I'll see you back, you know, in 6 months, or I'll make this set of recommendations and, you know, you should be all better. You really need to follow up with these individuals. They also defined bell ringers, or you know, made a comment that bell ringers themselves, dings, things that we think of as maybe, you know, individual didn't have full-blown concussion symptoms at the time, but boy, they really looked out of it for that brief second, and you know, they just kind of got a good ding. That those themselves may be some subclinical type of disturbance. While albeit transient, those impacts over time may add up and may predispose an individual to having a worse outcome if they do get injured. And an example, story that I can tell you with my son's example, I think will kind of drive home the point. He was 4 years when he slipped down our stairs. Our stairs are carpeted. He had socks on. He just kind of lost his footing and sort of, I didn't see it actually, I just kind of heard step, step, thunk, thunk, and then crying, and ran down, and he was kind of, you know, rubbing his head, and he was alert and coherent, but albeit hysterical for the moment, and soothed, and I rocked him, and I looked at him, and he seemed okay, and we took it easy for maybe an hour, and he had lunch and kept it down, and you know, within moments after that, he and my daughter wanted to play. There's 14 months between them, so she was 3, and she probably about half his size at the time. And they were running around playing this game where they'd run around our couch and dive into a little pop tent we had in our basement. And he was coming one direction, she was coming the other. They didn't see each other, and they just collided. You could hear the bonk, you know, probably outside our front door. And she immediately just stood there and kind of rubbed her forehead and said, "Oh!" And he said nothing and just sort of fell to the floor and pretty immediately started to just projectile vomit and was out of it. And that continued for several hours before we finally called the ambulance, and they came and we went to Mary Bridge. So, you know, I wonder now about that flight down the stairs, and should I have sat him out for the day? And if I had, even though he looked fine, would he have fared better in the next 48 hours? My guess is he would have. And that's more my anecdotal experience. I don't know that there's a research base looking at that per se, but I think that's what we're talking about here when we're mentioning bell ringers and transient events, but, you know, what do we want to do about them? Right now, the recommendation also is, that from the standpoint of rest, you hear a lot about rest. I'm going to talk a lot about rest today. That, it's pretty clear that from the time of injury for about 2 days, you really want to sit them out and pretty much have fairly complete rest. So, we're going to talk about the levels of symptoms, but in terms of those physical, cognitive, emotional symptoms, you really want to sit individuals out physically, cognitively, emotionally, just, take a couple days out to completely heal and have the best opportunity for outcome. But once we're looking beyond, those first 48, 72 hours, now dependent on other risk factors, there's a question about how much additional rest is helpful for you, or is it actually becoming harmful? And we'll talk about that in terms of why. The more recent literature is suggesting that graded exercise is helpful even if symptoms are persisting. So the core areas, physical, cognitive, emotional, and sleep, which is a physical symptom, but we call it out uniquely in and of itself because it really can impact all the other three. Physical symptoms are probably the more common things we think of with concussion. I mean, if I were to say, tell me what's on the top of your head when you think of concussion, these would probably be the things you would tell me. Headache, nausea, vomiting, imbalance, really drowsy, fatigued, kind of seeming in a fog. Sometimes we talk about, how many fingers, blurry or double vision. Individuals can have hypersensitivity to sounds, to bright lights. Anecdotally, my kids have told me that I've worked with, it's really sunlight more so than academic or institutional light that bothers them. Although I do have some kids that go back to school in sunglasses for a period of time because they say that they're bothered by lights in buildings. With cognitive symptoms, there's less impact on those firmly rooted, crystallized, stable skills like intelligence, general language, long-term memory. So who's your mother, how many people are in your family, I mean, that kind of information, most individuals are going to retain that with a concussion. It's more a grocery list in the moment. Where were you on the field when you got struck? Things either at the moment or short-term kind of memory that's impacted. So the areas of highest risk with cognitive symptoms, one's awareness and orientation. One of the common questions that kids are asked on the sideline, where are you now? Who are we playing? What was the score? Attention is certainly impacted. Mental flexibility, the agility with which one can kind of go back and forth between a number of tasks. And I say that to parents and most think, well, most of us only do one task at a time. Not really. If you think about yourselves right now, you're paying attention to me, you're taking notes, you've probably checked your cell phone 2 or 3 times. You're thinking about what's relevant from what I'm saying that you want to write down. You're multitasking all the time. You're also not paying attention to maybe the hum of the lights, the feeling of the chair on your back or under your legs, so you're able to ignore certain sensory input. You're doing a lot of things right now, all at the same time, which were we to reduce the resource that your brain had to attend, you might suddenly find yourself really distracted by all of those things. Other areas, working memory, executive functioning, processing speed. So in general, I would say individuals are slower to process information after a concussion, and reaction time. Also, it's important to kind of recognize, I think this is kind of a common knowledge that we might not always think about, cognitive challenges can have broad effects, right? So even if it's not in the domain that I just listed on that previous slide, it's going to play a role. I have one kid who became increasingly more asocial over time related to concussion symptoms, not because she didn't want to be social, but because she was having so much difficulty organizing her thought from an executive functioning standpoint and holding information and working memory that she literally couldn't remember what she had told people versus what she hadn't told people. And her friends were all either finding her conversation to be really patchy or really repetitive and redundant. She was saying things as if they'd never heard it before. So it starts having more broad-reaching impact, certainly, than the actual symptoms themselves. It's also important to know that the trends may be really subtle. It might be not something that you pick up right away, but they're still very significant. Usually the individual can tell something's just not right, or the parents or the teacher can tell. And it impacts all areas of daily functioning. The emotional changes that we see, I think the easiest way to think about it is whoever you are, if you've been given a concussion, it's a higher probability that you're going to have a much shorter fuse. So the things that might normally roll over you, roll off you, the things that you could kind of roll with the flow kind of thing, become much more challenging for kids and individuals with concussion. So more prone to irritability, lashing out, maybe tearfulness, laughing, crying. There's just sort of more of an up and down with concussion symptoms, so more prone to reactivity. Certainly anxiety and depression we see, frustration, sometimes a real sense of hopelessness that it feels like it's going to go on forever, or I just don't like this feeling. And then certainly, particularly with the high caliber kids, student athletes, most kids who want to go back to the playground, back to school, a tendency to want to downplay the impact of that, even though it's there. I want to talk a little bit about how symptoms present over time. So the first thing we see, moments to days, tend to be this core set of symptoms. So these are the things you would see on a sideline right after a blow to the head. I saw it in my son after he fell down the stairs. Confusion, disorientation, retrograde or anterograde amnesia, so forgetfulness either for events leading up to when that accident occurred, as well, or potentially for memories after the event. So I have one athlete that I remember that was a soccer player who got injured in a game. They weren't sure if they really necessarily thought she was concussed. They allowed her to play the rest of a tournament that weekend, and she, for the life of her, still does not remember that she had 2 other games. So she was literally on the field for 2 90-minute games, has no recollection that she played after her initial event. Headache, of course, nausea, vomiting. We see motor weakness, incoordination, dizziness, the sound sensitivity, light sensitivity, etc. Later, and I put later in quotes because I don't mean to say that these symptoms are not there from the get-go, although we'll talk, there are some symptoms that evolve over time. It's more that these are not the things that we're necessarily evaluating on the sideline or right afterwards, right? What we're first looking at is, are you okay? Do you have a headache? Sit down. The individual starts to vomit. We're dealing with that. We're not asking them, okay, do serial sevens in your head, or having them do mental arithmetic problems. Were we to do that, we would probably see a lot of these symptoms at the get-go. But these are some of the things that evolve or that we tend to notice over time. We tend to see them around 3 to 4 days afterwards. I think the reason we do is because that's when the physical symptoms tend to subside. And so it's not that the physical symptoms, or that these symptoms were not there, it's that over time, as the physical symptoms go away, suddenly it's like, oh, I thought you were better, but you're really not. So it's the processing speed, the short-term memory impairment, difficulty retaining new information, irritability, the fuzzy feeling, etc. So this is just a clip from a student athlete that had experienced a concussion. I find it helpful always to get just kind of a direct patient view, so I'll play this for you so you can kind of hear for yourself. So I think that that's just a helpful little infomercial that kind of helps drive home the point and to hear from an athlete herself about what her experience was like. Let's see if I can get this. I think I do it this way. So I'm going to talk a little bit about some of the frequencies of concussion by age, by gender. So first by age, in peds, high-risk groups, children ages 0 to 4 tend to be the highest age group for experiencing concussion symptoms, followed by adolescents 15 to 19 years of age. The 0 to 4 year age group, both from the standpoint of vulnerability of their brains, sensitivity to cerebral swelling, there's a higher probability for potential cerebral swelling in young children under 4 than there is for older children. The 15 to 19 year age group maps on both to their increased activity level as well as to motor vehicle accidents and learning to drive and risk taking. That 0 to 4 age group as well, sadly, there's been some speculation about those statistics in relation to non-accidental trauma and or child abuse increasing the incidence. Traumatic injury by gender. In general, all things held constant, you're more vulnerable to getting a concussion with a blow as a female than you are as a male. For similar sports, similar position on field, etc. The more recent statistics that I've seen, which was assessment based on questionnaire sent to athletic trainers of many, many high schools throughout the United States. I think these statistics came out in 2013. Found 1.7 on average per 10,000 athletic exposures, and athletic exposure being a timeout on the field. So for 10,000 moments or times of uniquely going out onto the field, there's a risk of 1.7 per 10,000 of those for females, 1.0 per 10,000 for males. Boys 0 to 4, again, we talked about that, are the highest rates, and certainly of TBI-related ED visits, hospitalizations, and unfortunately death. In general, and this is literature, not just pediatric, but literature overall, leading causes of traumatic brain injury: falls. The unknown category, I apologize, I didn't catch that till later. I think it's just they had a hodgepodge of various things, and that was multi-trauma. But the other one that's very high, as you can see, is motor vehicle accidents. In high school sport, the percent of overall concussions: football, no surprise there, followed by girls soccer, boys wrestling, and girls basketball. The mechanism of concussion: most likely to get a concussion via player-to-player contact. That's roughly 3/4, and a little less than the last quarter of impact of player to the playing surface. So the field, the goalpost, the gym floor. And if you want to know what not to play, 22% of hockey injuries are concussion. So leading causes, we talked about this: struck by or against events, can be colliding with a moving or stationary object. A little bit about impact science. This was from a previous talk I did. I don't have as much time to go over it, but they're doing a lot of great research with impact science, where they're actually putting linear accelerometers inside the helmets of players and measuring the G-force when a player gets hit. And they're actually looking at various positions on the field, as well as the level of sport. And so what I really wanted to share with you when you think about kids and sports is when you compare how hard individuals are getting looked at. This took the general G-force, and these studies allow me to compare the NFL professional athlete studies with collegiate and high school. And if you look at the number of G's in the linear accelerometers between NFL and professional athletes versus high school, I don't see a whole lot of difference there. So they're getting hit very, very hard, and it's important for us to be thoughtful of that when we're returning kids to sport. I also think it's important to know a little bit about the biomechanics of concussion in terms of what's going on physiologically, and what schools of thought and what bodies of literature inform us about how an individual is going to respond to a concussion. And there's kind of 4 main areas that I want to point out here. One that I'll talk about just briefly is the metabolic cascade. Another is just the information about the general developing brain neuroplasticity versus increased vulnerability. There's some research on overuse, mainly from animal models, but I think you'll find it interesting. And then, certainly the neuroanatomical structures that are involved, dependent on what's involved, is going to influence how you respond to a blow to the head. The metabolic cascade, I think the biggest take-home message I want to leave you with is that there are neurochemical cellular changes that are happening in concussion. That's really the level at which changes are happening at a metabolic level that we cannot necessarily measure at the time. And I don't believe that we fully understand with human models. We've looked a lot at animal models. But what we are seeing is that the brain kind of goes into this state of metabolic shock where the energy demands for recovery don't meet the energy that's available to the brain. And so the brain sort of goes into this state of shock. And during that state of shock, there's sort of a heightened vulnerability to getting another blow to the head. And that increased vulnerability is sort of a bell curve. So it does not happen, well, it's happening starting from the time of injury, worsening, 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 kind of peaking off and then settling down. And there's some belief that it peaks between 48, 72 hours, which is right around the time when we're seeing physical symptoms look like they're gone. So again, another cautionary note about returning individuals to environments and particularly to play too soon, because their brains at that level may not be quite ready for it. From the standpoint of the developing brain considerations, those of you in psychology and behavioral sciences understand this. So we know a lot about neuroplasticity, and we kind of grow up in our fields understanding that younger brains are still developing, therefore they're more resilient. That if you injure certain neural tracts, you have an opportunity to form new tracts, and therefore recovery, it bodes well for recovery. However, the other sort of literature that informs us is that young brains are also more vulnerable. There's a higher incidence of mortality related to increased cerebral swelling. So it's not, all good news with little kids. It's still quite dangerous. And there are certainly animal models to support both factors. Studies about overuse and implications for exertion. So, you'll all remember we're kind of wired contralaterally, right? Right hemisphere controls the left side, left hemisphere controls the right side. They look at rat studies where they have actually taken rats who have unilateral cortical lesions, and then they've put them in exercise treadmills or in mazes, and they've restricted use of the limb that would correspond either to the side that was injured or the side that was not injured. And what they have found is if you injure a rat and you restrict the limb that corresponds to the non-injured hemisphere, then you have better recovery if you restrict the limb that corresponds to the injured hemisphere, meaning I can't use that limb, so I'm not relying on my injured hemisphere as much, then you have improved recovery over time. It's more rapid. And the belief is that because I'm not relying on that injured cortex as much, that injured cortex is able to heal at a more rapid rate, and I'm able to recover. Whereas if you restrict the use of the uninjured forelimb, the forelimb associated with the uninjured cortex, you see worsening of the lesion itself. So, basically the suggestion is if we return too fast with injury, we may really be increasing the likelihood of further risk over time. In the study, there was a little bit of mitigation for delayed use because there was no lesion increase, but functional recovery was still delayed if they allowed the injured forelimb to be used. So again, rat studies, just a few of them, but I think the research is very interesting. Some additional considerations about returning to activity. As I shared, complete rest beyond 3 days is probably not helpful in most cases, not all, but most. So, I wouldn't recommend that you necessarily after 3 days keep an individual in bed with the shades pulled as if life isn't going on. Now, some kids, some adults, they are going to struggle and you're going to need to do that. But I wouldn't say as a rule that's the way to go. Generally, you want to look at gradual resumption of pre-injury non-impact activities, and you want to kind of start it slowly as tolerated. Supervised exercise can be helpful. And I think I want to put a cautionary note about the mindset that we give to an individual. And this is, when I've been talking to providers, it's a very different message a parent hears in the ER if the family's told, now I need you to go home with Johnny, turn off the lights, put him in bed, and don't do anything for 5 days. Versus, keep an eye on him, see how it's going. If he can tolerate it, you can do it a little bit more the next day. If he can't, maybe go back to bed. That parent feels a lot more hopeful, and there's a lot less catastrophic thinking involved about returning. I think in general, it makes sense that we can set the expectations in the vast majority of cases that full recovery will happen. We talked a little bit about the evolution of symptoms. Some other points, physical symptoms and altered mental status are usually the first things seen. The physical symptoms tend to improve before the cognitive. Cognitive symptoms may worsen during the first 48 to 72 hours related to that metabolic cascade. One study done in '96 looking at Penn State college athletes matched, I think this is just a profoundly interesting study. They matched players to controls based on sport, position of field, and even sort of educational attainment as much as they could. And then they did studies of these kids pre-season and then at the time of an injury. So if you were an athlete on that team, you got paired with another kid that played the same position, you both went out onto the field for the season. If one of you got concussed, you both got brought in, and at 2 hours after injury you were assessed, at 2 days after injury you were assessed, and at 2 months after injury you were assessed on both cognitive and physical symptoms. At 2 hours, when they compared the concussed athletes to their controls, they found that both physical and cognitive symptoms differentiated the groups. No surprise, right? If you look at a bunch of concussed versus non-concussed athletes, the concussed athletes look worse. At 2 days, the physical symptoms no longer differentiated the two groups. So the physical symptoms were gone. Both the concussed and non-concussed athletes looked the same. The cognitive symptoms still differentiated the group. But the most fascinating finding for me is that the evaluations of the cognitive scores at 2 days were worse for the concussed athletes than they were at their own 2 hours assessment. So they got worse 2 days later than they had been 2 hours after getting hit. And that's sort of that evolution of the metabolic cascade happening over time. So I think it's important to take that point home. So I'm going to kind of finish with us talking about management and some strategies here. I want to kind of preface this again, bring you back to those 4 core areas that are impacted by concussion: physical, cognitive, emotional, and sleep. And we'll talk about sort of a phased approach. So there's the acute phase of recovery, which is really the time of injury to 3 days afterwards. Then we talk about the post-acute phase, which is from 3 days forward. And then once in a blue moon, and this is many of the kids, unfortunately, that I see, we see a subset of kids that have what we call prolonged post-concussive syndrome, which are symptoms that are lasting greater than 3 months and forward. The management timeline for mild traumatic brain injury, generally you're starting out with activity restriction that's determined by the extent of your current injury, any past risk factors, and we'll talk about those, and the functional presentation at that time. How does that kid look? How does that person look? And then you use ongoing evaluation to inform treatment needs and monitor trends. So in that acute phase, what are we doing for the first 0 to 3 days? Not an awful lot. Suggesting that the patient rest, reduce stimulation. So yes, lights, yes, not allowed, a lot of loud noises, but we also suggest no texting, not a lot of, don't go to the movie theater, don't go to the school dance, don't watch the football game even though you can't play in it. We don't recommend that they go to that lousy kind of, or loud, rather chaotic environment. That noise can be overwhelming. Again, for that first 3 days, I would say the rest really needs to be in all of those major areas. So physical rest, cognitive rest, don't do homework, don't have the student bring home the work that they're missing while they're laying home in bed. We don't want them to be working on anything. Reduce their exertion. I also tell families now's not the time to have the big, heavy, and real conversation about whatever, when I get to drive, the night that I came home late with my girlfriend, whatever it might be. We want to reduce the emotional stressors as well. So even emotional rest is prescribed for those first 0 to 3 days. So it's really just a lot of rest, don't do anything, and don't put any more demands. From 3 days to 3 months, then we're starting to kind of base it on what the individual's unique presentation is. We're assessing what their rehab needs are, looking at reintegrating to school, starting to provide education on various provider roles. A lot of kids have a lot of various providers on board. They might be seeing a neuropsychologist, a neurologist, a sports medicine doctor. It's really important for them to understand who's doing what and for us to try to minimize duplication of services. We start doing some brief directed cognitive assessment of the areas that are sensitive to concussion, like processing speed, executive functioning, organization, tolerance for stimulation, reaction time. And we start setting up the restrictions and the permissions over that period of time. I'm gonna, can one of you grab these and you can just, I don't know if I have enough of these, but I wanted to bring these, and if you guys email me, if you didn't get one, I'm happy to send more to the university. Yeah, so this is a good summary, I guess I would say, and what I like is it's a guide that we put together, one of my colleagues put together with one of her mentors, and all of us kind of had editing privileges, I guess. It describes what a head injury is, the recovery course, and what's to be expected. It talks about symptoms and management, and it has some nice resources at the back. It's meant to be given to kids, you know, school age and over, to be going over it with them. So we give it at the bedside, we hand it out in our EDs. It's a nice thing for a school nurse to have to go over with parents. And again, I can get more copies too, but I just wanted you guys to have a copy. In terms of cognitive symptom management, so we talked about cognitive rest, and I'm going to talk a little bit more about what that is, and I also have a little clip that's going to talk about what that is. But it's really, I can't underscore enough for families that I work with how much our brains are doing all the time, even when we think we're resting. So, you know, we're paying attention to stimulation. We're deciding what to attend to. We're thinking about what we're going to have for dinner when we go home, or what was that assignment that I needed to work on tonight. There's constant information coming at us. We're also being bombarded by sensory stimulation, lights, sounds, noises. All of that is putting some type of demand on our brain. And it's using up resource. Most of us, it's not a resource that we even notice being utilized. But were we to have a concussion and have reduced resource going to those things, we would notice the difference. And so cognitive rest is really about saying that our brains, in fact, do not have unlimited resource, that there is more resource going into concussion recovery. And during that time when there's more resource going there, we need to limit the information coming in and what we're expecting the student to do to allow them to make best use of the resources and the faculties that they do have available to them. So when you see the recommendations I'm going to go over, I want you to think with that in mind. It's all about how are we limiting what we're expecting in terms of multitasking, taking on information, etc. And this is a little clip here about cognitive rest that'll kind of drive home that point a little bit more. So I think that's helpful to know about. I think that this has become more looked at in the past 5 years or so, but I think it's a newer dynamic in management of concussion than we used to have. There used to be a lot of difficulties that we dealt with schools in terms of, you know, wanting to send homework or not understanding why we were limiting the student's day or why that student was allowed to go to such and such, but couldn't tolerate a full day of school. I still deal with that, and I think that's a point I really feel is important to educate about, both from the standpoint of getting back to life as much as they can. This is very different from sort of, you know, when I grew up, my mom had that, you know, mentality of if you're too sick to go to school, you're too sick to, you know, yada, 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 yada. This is really not like that, you know, so I definitely have had kids that I've cleared to go back to certain aspects of their athletic endeavors and still have not cleared for a full return to academics. And it's that balancing of physical exertion and cognitive exertion, as well as stress release and getting back into their social world and all the benefits that they're getting of having those things, you know, fall back into place. So keep that in mind, because I think for some people it can feel a little odd, and it's really done purposefully. What if they're not getting better? First thing is not to panic. You know, 10 to 20% of kids with concussions can take 3 weeks or more. It's also more likely that younger children will have a prolonged recovery as compared to professional or collegiate athletes. So 10 to 14 days is the window we give for kids. A week to 10 days is the window that we give for high school athletes and college students. Younger kids tend to take longer. We talked about that. And again, I think it's important to underscore, even if it takes a while, the full expectation is that they're going to get better. Why do some take longer? And earlier I had told you it's part art and part science, right? Well, the art part is understanding the risk factors. And as psychologists, behaviorists, these are things that are important to know about. So in bold, I would say, are the kind of the 4 main risk factors that I ask about when I'm assessing a family at baseline. When a child has had a concussion, I want to find out about psychosocial stress, particularly any psychosocial challenges at home, premorbid psychosocial history, psychological history, any chronic medical conditions, difficulties, things that are just going to stress the system in general. Those kids tend to have poorer outcomes. History of learning disabilities. And again, just from that standpoint of the brain does not have infinite resource, and if we're giving resource to something and we suddenly make it focus on something else, now there's less resource to go there. So any of you that have learning disabilities, any students that you've worked with that have disabilities, they're working overtime to compensate, right? If you then give them a concussion on top of it and they don't have that extra resource to go into attending or dealing with their dyslexia or their math disability, it suddenly looks like it's gotten worse. But it's not gotten worse, they just have less resource to kind of deal with it. So I usually tell parents, whatever those pre-existing kind of areas were, don't be surprised if it looks like we turned up the heat on those things for a period of time. And I would say over time it gets better, but if you have a kid who's got LD, who then gets concussed, I would say look at the time given to that LD area because they may need more of it. Previous history of concussions, if you have had one, you're slightly more vulnerable to having another one if you get struck again. If you've had 2, you are nearly twice as likely to get another. By getting another, what I mean is not that you're going to get hit again. Again, think of the functional disturbance. What I do mean is that if you get hit again, it's going to take less impact to potentially have more functional disturbance over time if you've had more injury. So I'm very interested when I see kids in knowing, is this concussion number 1? Is this concussion number 2? Because I'm really treating their symptoms differently and more conservatively over time in terms of what I'm clearing them for. Also, if you tend to be predisposed to kind of being a headachy kind of person with stress or in general, or have a premorbid history of headaches, you're more likely to have headaches with concussion, and also a family history of headache. And then finally, sleep problems. Sleep problems just tend to make everything worse, and I've got a slide here about sleep. I want to give a little comment to the case of the high achiever. I'm guessing most of you fall into that category. I'm thinking mainly of my high school students that I deal with. A lot of the kids that we see, they have a prior history of being very high performers and doing very, very well. And they're used to that nose to the grindstone mentality. And you give me another assignment, I'll just spend another hour tonight doing it because that A is really important to me and I'm just going to do what I need to do, right? Suddenly they have these overnight changes in functioning. Their grades, if they're really bright kids, may not noticeably drop from a teacher's perspective, but they may be working 3, 4, or 5 times harder at home, spending 3 or 4 more hours of homework at night to get that grade. And oftentimes we struggle to get kids qualified because the teacher's like, are you kidding me? I need 10 more of this kid in my classroom. He's still getting A's, or gosh, now it's an A-, really? I mean, you're gonna split hairs over that? Yeah, because this kid's spending 5 hours at home trying to get that A now. And so we make academic accommodations not based on grade, but based on challenge and how hard is this student working and where are things starting to fall. In terms of managing symptoms, I'll hit just some highlights because I want to save some time for questions and I still have a lot of the recommendations to go over. So obviously it makes concentration difficult. Dealing with sensory stimulation, I would say that's the first thing to ask when an individual has a headache with concussion is what's coming in from the sensory field and how do we limit that? Can we limit the noise? Can we limit the sound and the lights? How much have they been doing? Do we need to take back or walk away from the screen for a little bit of time? Sometimes a little break can go a long way. Limit non-steroidal anti-inflammatory medications. So that's what the NSAIDs are. Ibuprofen, Aleve, not as helpful as Tylenol. Focusing on sleep. Sleep is very important in management. Vitamin B, magnesium, fish oil has been shown to be helpful, and occasionally we're looking at other medications that you could certainly refer to a neurologist or primary care provider for assistance with. You know, I think it's really important to get rid of headache. So, you know, if you are working with individuals who report that, well, they're generally a lot better, but they've had this headache forever, I think it's worth bumping it up a notch and looking at a neurology referral. Other physical symptoms, we deal with dizziness. Usually we're looking at vestibular therapy for that. Individuals who have a lot of lightheadedness. Oftentimes I have families, you know, I ask about symptoms when they get to my office, and I ask about nausea, vomiting. You know, he was fine until we came to see you, and it was because of that car ride and the postural change, and they can't manage the ride. So I try to warn families about that. We do a lot of work around careful, you know, sitting up in bed, count to 3, stand up, count to 3, then take your first step to kind of do that slow positional change. Neck strain can often be present, can impact driving, looking over the shoulder. We tend to treat that with heat, massage, sometimes muscle relaxants, and certainly PT referral. Sleep, I mentioned, and I highlighted this one. You know, sleep in general makes most things work. Many of you are students, so need I say more? You know what it's like to be sleep deprived. Imagine you're certainly not at your cognitive best if you don't have sleep. If you were also headachy and not attending well, and then you couldn't sleep, those symptoms would be even worse. So it's important that we aggressively treat sleep disturbance when it's present. From a mental health perspective, we talked about mental health presentation in families being a risk factor. I also think that head trauma has a way of unmasking, as do most stressors, I guess, unmasking mental health problems in families, right? Depression, anxiety, kids who are psychosomatic, we see those presentations. I also think it goes without saying, concussed kids, especially if they got concussed in sport, not only are they dealing with the concussion, but now we're taking away their best coping strategy, which was the sport, which was how they reduced stress, right? So it's sort of this double whammy that we really try to work with. And we want to offer, psych referral, mental health referral wherever we can, as well as education can be very helpful, which is partly why we developed that brochure for them. So I'm going to kind of go with specific symptoms now and kind of talk in certain domains of functioning. And I won't hit all of them, of course, but so from the concentration and short-term memory difficulties, that's very common, can play a role in pre-existing learning issues. We may look at stimulants to deal with attention problems following concussion. Sometimes we look at cognitive rehabilitation, and certainly a neuropsychology referral can be helpful. So in terms of returning to learning or the return to learn process, first thing, I'll give a plug for my discipline, but I think also neuropsychologists, that's the role we kind of play uniquely in concussion management, is really around that cognitive symptom management. We provide education about the management, we screen for the presence of pre-injury risk factors, look at cognitive challenges, and can offer support around school issues, changes in behavior, undue parental or coach pressure around return to play, and any need for cognitive clearance for return to play. Usually the returning to play decision is a team decision. Ultimately, I would say we leave it to the medical providers, the primary care provider, the sports medicine doc, but many times they're coming back to us saying, okay, I'll clear, but I need to know what you think cognitively. So it really is a team choice. It's a collaborative effort. Obviously, the goal is to reduce the risk and the likelihood of failure. And we want to set clear goals with the student. We want them to be successful, and we want to monitor them throughout their recovery. So first thing we want to look at is modifying their schedule. And what I've tried to do is put what the modifications are and what the concussed area deficit is that lends itself to needing these modifications. So from a school schedule, keeping in mind that these kids have reduced endurance, they fatigue more easily, and they have processing speed impairments. So we want to reduce their school day time in general. It's hard for these kids to get through a full day of school. I usually recommend a gradual return to school, start with a period, do that for 2 to 3 days. If that goes well, let's add another class. Sometimes they stay at 1 to 2 periods for the remainder of the semester. More frequent breaks in school during the day. An additional study period or study skills class, often we drop a class and add that in for homework time. You want to, if you're looking at dropping classes, we look at dropping classes that have a heavier load on the requirement for new learning of information, because that's an area that tends to be more predisposed to challenge. So things like foreign language, higher level math courses, a lot of the AP classes. Safety precaution, this plays a role in the increased vulnerability of the brain following concussion, the slowed reaction time following concussion, and increased distractibility following concussion. So early on, at least, we recommend no PE until cleared, no activities in the gym or on the playground until cleared, no wood shop, no auto mechanics, any class that's using any sharp objects, anything where there's a risk of injury. And early dismissal from class during change of period due to the imbalance and to reduce risk of being struck in crowded hallways. So all of those accommodations can be very helpful to the students. Also, with the no PE, again, just a plug for the poor kid who's being kept out of PE in recess. You know, I always like to put in my letters, please don't put them in the school office for 45 minutes every day. Please don't have them sit alone in the library. We recommend that they get to pick a peer buddy, that buddy gets to hang out with them, that they get to play board games, and that rather than adding, you know, insult to injury, we actually let them feel like their time off is also enjoyable, just like the kid who's having recess. Environmental accommodations related to inattention and sensory sensitivity, preferential seating at the front of the class or in a quieter area, reduction of distractions. We've had kids who have taken tests with headsets on or earphones on or earplugs, testing in a quiet environment. You know, potentially not going to the school assemblies, not going to the orchestra presentation, dropping band, etc. In terms of adjusting requirements for grading, again, keeping in mind that the kids have reduced cognitive resource, they're fatigued, they're high achievers, we want to reduce their emotional strain. So we request outright forgiveness for any missed work. So when kids are in the hospital, usually their biggest thing is, I gotta get out of here, I gotta get out of here, I'm missing school, we have a test, I already had this project I was working on, and we try to say right outright, we're going to write a letter to the school, we're going to recommend that you not have to do that project, we're going to recommend that you only do the essential, absolutely essential assignments. So we really don't have kids doing missed work wherever possible. We also recommend that they only be graded on what they complete, so that they get an opportunity to try work, but then when they need to sleep, they need to sleep, and that they get graded on what they did, not, you know, the 5 problems that they couldn't get to because they were exhausted. Other options include freezing grades, assigning incompletes, using a pass-fail option. In terms of modifying the assignments themselves, decreasing the workload, sometimes, you know, especially if this is really helpful for assignments where it's a lot of drill exercises for practice, like math, or certain science questions, or certain vocabulary terms. So maybe doing every other problem, or only working for a certain amount of time and then putting it up. Allowance of aids like calculators, computers. Again, the brain can only do so many things, so, you know, we encourage the teachers and the people who are writing the 504 to think about, what exactly are you testing here? And can we allow some aids for the things you're not testing? Are you testing critical thinking? Are you really testing, you know, fundamental math skills? Assigning a peer note taker, I often ask the teachers or professors to give a copy of their lecture notes, a copy of their overheads ahead of time, anything that would allow that student to just sit and listen and not have to be writing, taking notes, looking back up and forth at the board, which can play a role in their next strain. Modifying tests related to some processing speed challenges and retrieval. We always recommend an untimed testing option. Occasionally we suggest open book or cheat sheets or prompting cards to kind of get, kids struggle with retrieval more so than they do recognition memory. So if you give me a multiple choice test, I can probably tell you which one's right, but it's really hard for me to pull it out of my brain if you don't get me started. And assistance with the first few steps in a problem can be helpful. Some support for new learning, review the previously learned academics, pairing material, chunking. These are all common strategies. I'll let you look at those later. Organizational aids also can be very helpful, as well as just reinforcement, redirection. I oftentimes recommend that the student meet with a guidance counselor once a week. A lot of the kids, especially high school and college kids, won't raise their hand and say, I'm really struggling. But if you bring them in once a week and you say, so how are you doing with this assignment? How are you doing with that assignment? How are you keeping up? You'll get a lot more information. Around return to play, physical return to play, and again, this is not something I necessarily manage in my domain. I want to be clear about that. I just wanted you to have the information. We do this with the guidance of sports medicine providers. Usually it's a graded and gradual return to play, starting with general conditioning, moving through more intense conditioning, finally to non-contact scrimmaging, and eventually to full contact, assuming that at each step the patient doesn't have a worsening of symptoms. If there's a worsening of symptoms, then you back up. You all may have heard, and this is something oftentimes used in clinician offices, there are computerized assessment instruments. The one that we use is called IMPACT, and that's probably one of the more commonly used measures. It's used by the NFL, the US Olympic hockey team, the NHL. They're basically a 30-minute sit-down, 5 or 6 domains of assessment looking at processing speed, reaction time, memory, word list, distraction, all that can be done at a computer. So what a lot of the colleges are doing, what the NFL now does is pre-season sits everybody down in front of the computer. They all sit down and they take the IMPACT test. And then if the individual gets a concussion, they bring them back in and they retake the IMPACT test. So they're compared back to their own original baseline. And it has infinite sort of, because it's computerized, re-administration opportunities because you can vary the administration. Certainly the individual can still be predisposed to practice effects, but not nearly to the same length that you would if it couldn't be varied. Some of the cons, there's still some question about what are we truly measuring. As a neuropsychologist who measures a kid for 8 hours, when I'm looking at a neuropsych assessment, to break it down just to a half hour, I feel like I'm losing a lot of information. So that still makes me nervous. Question is, does less data lead to less ability to generalize? I don't know. I think what's helpful about the IMPACT is if you're a primary care physician and you don't have any tool, but you have IMPACT, it's a really nice thing to have, and it gives you some data to monitor over time. So I definitely think there's a place for it. It also requires careful oversight of administration. There's been some suggestion of teams trying to dumb down their baseline findings so that if they do get a concussion, they don't show as much of a detriment between time 1 and time 2, and they can get back to the field more quickly. So it's something that has to be monitored. Outcomes, increased risk for another if you've had one with more severe presentation. So first, take home. In the future, if you've had one, it will take less impact to potentially do more damage. The effects can be cumulative. Certainly there can be potential catastrophic outcomes, which is why we don't allow kids to return to the field. Longer recovery periods with kids, rapid early recovery from a moderate or severe TBI, but we are finding that there's increased long-term outcome for Alzheimer's disease, Parkinson's disease, and other brain-related disorders like chronic traumatic encephalopathy for individuals who have sustained more moderate to severe brain injury. And again, moving towards prevention, a lot of you have probably heard about a lot of the things happening towards prevention. Certainly protection is key. You know, the football helmets now, a lot of them have air-based pads internally. So the individual puts the helmet on, it has the regular padding, and then it also has air cylinders and can literally be pumped up once it's on the head to really fully protect and fit around the brain. It's just one example of something that's being done. And then the legislation, this was the more recent CDC. So in blue is where the legislation has enacted, and you know, I don't know what's going on with Mississippi. They're just a little bit behind the times. For some closing thoughts, clearly multifaceted and complex injury. It's a functional disturbance. Some of the symptoms may not be evident early on because we're not necessarily screening for everything early on. There's also some evidence that things can evolve with that metabolic cascade. Recovery course is variable. Most individuals have a really good outcome, but when those risk factors are present, we have to be a little bit more conservative. And obviously, caution is warranted with all concussions, and return to activity remains a medical decision that takes into account physical, cognitive, and emotional factors. So I'm going to stop talking and let you guys ask questions or digest for a minute. And thank you for having me. I really appreciate the opportunity to talk to you. You all look like you're concussed. Got that deer in the headlights look of everybody. Yeah?
So I have a question about, you said that younger children tend to take a little bit longer to recover from a concussion, yet they have neuroplasticity on their side. So could you, it seemed contradictory. Could you
Exactly, which is why I put that slide up. I don't know if I have a good scientific rationale. I think that the bottom line is that young children are, I think part of it is the reduced resource and the load on kids and the developmental needs and that sort of sponging in of information as kids are growing. When you think of the monumental curve of learning that's happening at that time, and then you give that brain an injury and you impact things like new learning and short-term memory and emotional regulation and sleep, it's going to have a big impact on a kid that's developing hand over fist, you know, exponentially. The likelihood long-term that they'll have good recovery, I think, is enhanced by the neuroplasticity argument. But I think that from a developmental trajectory and what the demands are for learning at that period of time kind of predisposes them to potentially have a longer term. They're also, you know, I mean, not only are their brains moving targets, but they're moving targets. And so, you know, I've had these poor, I mean, I had one mom that just burst into tears when I was trying to tell her, well, you know, now he needs to rest for 3 days. And she just looked at me like, have you ever had children? I'm like, yes, I do. But that's how I understand it. It's a good question, though. Any other questions? Yeah.
You know, so we have school nurses here, but we're all in elementary. So we try to assess these kids. We don't see the injury. They come in from the playground. And it's sort of like, you know, everything you ask them, oh yeah, not that, you know, are you busy, or you know. So it gets really hard to objectively assess.
Yeah.
The kids, because gosh, they're thinking, oh gosh, I'm gonna get to go home, or I'm gonna get to stay here, or you know, so.
Yeah.
And it just is really hard to figure out what. I mean, I've seen ones that are very obvious, mostly when I was at junior high. But
yeah, so you know, it's hard to say. The first thing I thought of when you said you're a school nurse and it's hard to assess is, you know, I came home one time and my daughter ran up and said, Mommy, look, I got a sticker today. And the sticker said, please be gentle with me, I had a head injury. And I'm like, who put that on you? And where did that happen? I think, you know, it was a well-intended school nurse who was like, you know, we're just going to make sure everybody keeps an eye. I'm like, could I have gotten a phone? Do you know what I do for a living? So But on the positive side, I think, you know, there is something to that. I mean, when in doubt, right, I would say a potential cautious approach. I mean, if a kid smacked their head or they show up and they're crying and they hit their head, I would do the best you can to assess them. There's only so much you probably can get, and certainly, you know, what they understand they're going to get out of the assessment probably does play a role. But I think, you know, basic parent education, certainly alerting family that the child had a mild blow to the head, I would probably be inclined to keep out of PE maybe the rest of that day. Encourage the parents, you know, that if you see X, Y, or Z symptom, they should probably be seen by their pediatrician. If you have any concern whatsoever, then my recommendation would be just to say, we want you to see your pediatrician before we're going to clear you for PE, because we're just going to be really conservative about it.
But you know, I have a 6th grade student that has a history of trying to get out of school. I mean, he spent 2 years going through cardiac clinic at Children's, and they could find nothing wrong. Well, now he had a concussion in the middle of November. He can do recess, he can do PE, but he misses school twice a week to go to physical therapy appointments for his concussion. You know, I mean.
So, yeah, and I think when you are in the trenches at school dealing with that, I think it's important to, where you can, I mean, if you can get releases to speak to some of those other providers from a team approach, you know, and I think that always makes sense to have a team approach to really make sure that everybody understands and lays eyes on this kid in terms of what they're doing. And fine, if someone's understanding it from a different purview, why recess is okay, but such and such is not, I would want to understand that medically and have that in writing at school to make sure that I feel like I can toe the line on that and that makes sense to me. And I think it makes sense to ask for that information in a way that makes sense to you and to keep pushing until it does.
Well, I have, but they're doing this just based on yes, well, I still have headaches, I still feel dizzy. You know, and because there's no really, like you said, you can't do a CAT scan and show that there's. So in that respect, it's kind of frustrating.
It is, and there certainly is, you know, the waxing and waning of symptoms. I mean, there are kids that look really good. You know, that's why I was mentioning earlier, I mean, I've had school nurses who are irate with me because they're so frustrated that I'm clearing this kid, or our team is clearing this kid to go back to non-contact soccer, but we're not clearing them for a full day of school. And that's just boggling everybody's minds, and, you know, trying to draw that line between physical exercise and the benefit of that versus constant cognitive exertion and the impact of that, and the importance to balance these things. And so, you know, again, I wish I had the magic bullet answer. I think part of what my discipline and what the medical field has not always done well, that I think it's important for us to own and to work on doing better, is to make sure that you're getting unified consensus input from the people that are working with those kids, and that if we're not giving it to you, that we're encouraged to get together and meet, or that it's drawn to our attention. An example I can think of is I had a kid, actually she was in our clinic, I didn't see her, she was just brought to my attention, but she was seen by neurology, sports medicine, neuropsychology, and her primary care doctor, and every single one of us wrote a letter to the school about what we recommended, and they were all very different. She was very depressed, she wanted to get back to soccer, she was struggling in school, and it ranged from the neuropsychologist who didn't feel that she was ready because she felt it was too much cognitive exertion and really could kind of see that as she did a lot of testing, to the neurologist who felt like her headaches were more related to premorbid headaches and that she probably didn't really have concussion symptoms anymore, to a sports medicine physician who felt like she could probably be on the field doing, you know, starting to get back to slow sport, to her primary care provider who said she absolutely needs to get back to sport and that's why she's depressed. And the school had all 4 of these letters signed by a medical provider, you know. So that was a huge wake-up call to us to, you know, we're not helping those kids any to send mixed messages. And sometimes, you know, we're only getting information from a certain lens from the family. So, you know, getting back to a school-based assessment and how do you deal with the school, you know, all I can say is when the more opinions I have, the more confusing it can get. I would, you know, sometimes we've called care conferences. We've gone to the schools and sat down with parents and nurses and, you know, the principal and the, you know, 504 creator, and just said, okay, let's all talk about what's being presented to try to get us onto the same page. But with those somatic kids, it's also very frustrating because, yeah, some of them really know how to work the system. So, and it's hard to tell, do you have a kid working the system or do you have a kid that's really having waxing and waning symptoms, and both could be true.
So I was teaching, you may have gone over this, so ignore my question if I missed the first part of this, but I was listening to the 0 to 3 days, the first part of the diagnosis and treatment around that, where you talk about complete rest around cognition and physical activity, and I saw you list the things of, you know, no texting, no TV, no screen time. So when you give that diagnosis to parents, I can see anywhere from early childhood to even adolescent. Do you give them suggestions around what to do with the child? I mean, I can see a child laying in the bed with just, I mean, I understand that around a concussion there's a lot of fatigue, that a child would be some sleep time, but do you give, what are suggested activities around that? Or
yeah, thank you so much for bringing that up. So I give that recommendation, and then I take a step back and I say, and I'm a parent, and I had a 4-year-old with a concussion, and I know what it's like to be in the trenches, and so I'm going to tell you these things, you know, after I go over, and our little pamphlet goes over, you know, photosensitivity and sensitivity to sound and lights, and so once I get the parents buy-in, like, oh yeah, okay, I get that, and then I say, so texting and flashy movies and playing the Wii all day, you know, may make things worse, and I'd recommend that we don't really do that. But if you're climbing the wall, or you need to make dinner and you need a babysitter and allow the kid to watch a program, I'm okay with that. Just small doses. Keep in mind it may exacerbate symptoms. If we have to say something as a rule, let me make the rule and be the bad guy at the bedside so that you can be the, you know, wonderful person that says, oh, we'll give you a half hour here, a half hour there. So that's kind of how I do it. I give it as the black and white education, and then I come back and say, but I know you live in reality and you can't chain your kid to the bed, and he already can't play sports, et cetera, et cetera. And so we kind of go with it that way. Because I also think, you know, what we lose in their activity, we add to in their emotional, you know, response to this. It's really, really hard taking away what these kids have, and so many of them are such talented athletes, so it can be really hard.
Could you just clarify, I learned this long ago in grad school, but I've forgotten, the difference between a mild TBI and a concussion?
There is no difference. You know, and really, we used to have sort of graded scales for concussion. Sometimes you'll hear a grade 1, grade 2, grade 3. We don't do that anymore. Or a level 1, level 2, level 3. We don't do that anymore. People used to split hairs between mild TBI versus concussion, and that's why I had that first slide. A concussion is a brain injury. There is no difference, you know, and I interchange concussion and MTBI in my slides, so they're all one and the same. Thanks for asking.
I'm just curious about one of the statistics you showed. It was 1.7 per 10,000 activity units for girls, 1 per 10,000 for boys. Substitute 1 split, right? In terms of that's all I was thinking. Like girls are twice as likely to sustain a hand injury on the coach. I'm surprised. I would have thought it would be boys sustaining more things. So do you have a sense of what?
I don't think anybody knows yet, but some of the conjecture I've heard is related to sort of the placement of the cranial vault and the anatomical structures of the heads and thickness of the skull, and, you know, mass in terms of velocity of injury and striking up against the skull. So we're looking at the researchers are looking at all kinds of factors. I don't think anybody really knows. But there's more and more evidence now that's coming out when they match for sport and position, et cetera, that girls are slightly more vulnerable.
Okay, so I know you said there's no such thing as stupid questions, but so if someone like has a high impact bump to the head and they lose consciousness, does that constitute a concussion, or is there a difference?
Well, a loss of consciousness would certainly be considered sort of a functional disruption, right? So, I mean, as a symptom in and of itself, you know, I think that would be one symptom we would be looking at. When the person came to, we'd be looking at a lot of other things, though. We would be assessing them on the side for things like, you know, headache, nausea, vomiting, awareness and orientation. You know, it's rare that you would have that type of a symptom in isolation. Occasionally we've seen kids where that sort of has been potentially, well, even, honestly, I don't know if I can think of one, but the ones where I can think of where the concussion presentation hasn't seemed clear, but the individual had a blow to the head, it was more likely either a fainting spell where they struck their head but had probably passed out before they ever fell, or a seizure. So, you know, but even then with seizures, you have the fuzziness and postictal period, et cetera, afterwards. So loss of, you know, it's uncommon that you would only have loss of consciousness. Usually it'll be loss of consciousness and. I would say if a person had a loss of consciousness and you don't see anything else, I would still want to keep an eye on that person because that's just not usual. You know, so if they had a loss of consciousness with a blow, or you're not sure how bad the blow was, but they definitely lost consciousness, that would be someone I would keep an eye on and would potentially send just for a workup to make sure you feel comfortable.
Sorry, just to go back to the TBI thing again, I just want to understand at what point then does something become diagnosed as a TBI versus a concussion? Is there like a clear difference there?
Well, more moderate, I mean, we start using terms like moderate and so forth when we actually have specific findings. So, you know, and particularly with medical providers, they'll make a big distinction, right? I would say the more finessed our measuring tools are, the more we think it's all brain injury, right? So neuropsychologists, psychologists, the brain controls everything, and if it's not working right, a learning disability feels like brain injury, right? Talk to a neurologist, and unless there's a bleed or, you know, something not wired right, it's not a brain injury. So it really kind of depends what lens you're looking through. You know, I would say, kind of as a general rule of thumb, I think in kind of more lay terms or just an easier kind of understanding would be we look more and we talk more about it as a real traumatic brain injury when there's some type of finding on a scan. If you didn't have a finding on a scan and you could have even horrific symptoms, we would still be using the term mild TBI or concussion.
Sorry, I know it's 8:30. But some of the headache symptoms you mentioned struck me as being similar to migraine symptoms. So I was wondering if a concussion could be a possible trigger for future migraines or anything like that.
Yep, and that's why we ask often about premorbid family history of headaches, premorbid family history of migraines, or patient having, you know, pre-existing history of migraines in general. Absolutely, we see patients who develop sort of a And honestly, that's usually what we refer to it as. If, you know, I have several kids that were a year or two out, and for all intents and purposes, everything else has resolved, but that headache just won't go away. And we usually have, you know, a pretty significant sort of sit down at a point where we say, okay, we're not calling this concussion anymore. You've developed a migraine syndrome. We're going to look at targeting your migraine symptoms, but we're not going to have you feeling like you're concussed for 4 years. So that's a good question. Thank you.
Oh, I was just wondering about the NSAIDs. I had not been aware that NSAIDs are not recommended for concussion headaches. And I was wondering if we know why that is.
We do not. You know, that's a slide I borrowed from one of my medical providers, in all honesty, when he and I had co-talked. So I don't know all the science behind that. I'm sure it's research-based, knowing him, and it's more likely that they recommend. And that was, I think, if I remember, was when sleep. I think it might have been in the sleep slide. So it may be more of the impact pertaining to sleep than just not recommended in general.
It's also possible because NSAIDs may increase bleed risk, whereas Tylenol does not.
True. Yeah. That's a good point. And if your rules depend.
Actually different than I think some people are going to head out.
Head out?
Yeah, but
I'm happy to stay as long as you guys want. If you have other questions.
we will lift the lecture. We hope by this week.
Where do you go to get that?